Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Coming up on the podcast today, I'm joined by our deputy editor Nick Bostock to talk about some of the key news stories affecting general practice. We're looking at how the GP contract change that requires practices to keep their online consultation systems on throughout core hours is affecting workload in general practice, and the increasingly bitter war of words between the government and the BMA about this issue. We're looking ahead to next week's England LMCs conference, where GP leaders will debate next steps on industrial action as a result of the dispute over online access. We'll also be discussing the latest NHS planning guidance and what that means for GPs, some good news from Scotland on the GP contract there and what it tells us about the difference between Scotland and England, and our recent analysis on how GP premises funding is being spent in England. Our good news story this week is about practices delivering award-winning end-of-life care. Before we start, just a quick message about one of our upcoming events. MIMS Learning Live North takes place on the 26th of November in Liverpool. The event will have 3 clinical streams providing practical and insightful clinical education delivered by experts. For the first time this year, we're also running a GP business stream at the event, which I will be chairing, and where we'll be looking at key issues including how general practice can get the most from the 10-year plan, the skills practice managers need to ensure the practice thrives, and advice on finance and CQC regulation. For more information and to book your place, visit mimslearninglive.com. And if you come to the event, do pop over and say hello if you see me. Hi Nick. So there's a lot to talk about today. A lot of things have been going on since the last news podcast, particularly around online access in general practice. We're starting to see how the change has affected practices, haven't we?
Yeah, so in the run-up to the 1st of October, which was the date when the requirement for practices to keep online consultation systems open throughout core hours took effect, we heard why GPs were worried about this coming down the track. The GPs wanted safeguards in place to make it impossible for patients to submit online requests that were urgent through online consultation systems, and they're meant for non-urgent cases only. They also wanted to be able to switch off the systems when they hit capacities, just to prevent practices being overwhelmed by a sort of flood of additional work. But the government in NHS England ignored those requests, as we've talked about previously. Now, nearly a month on from the change coming into effect, we're starting to see the actual impact in real life. What we're seeing is that GPs' concerns, that the concerns they were raising before the 1st of October are starting to be borne out, or have been borne out. So our senior reporter, Kimberly Hackett, who's not here this week, spoke to local medical committees about 10 days after the online consultation system change took effect. And LMC said that some practices were reporting being overwhelmed by additional work, just as they feared. They reported instances of urgent requests being sort of filed through these online consultation systems. In one case, for example, about chest pains. So that really speaks to why the BMA was warning about the potential for tragedy in the run-up to this change taking effect. As well as underlining just how this change puts huge pressure on GP practices. Another issue we wrote about in the run-up to the online systems change taking effect was that GP practices were concerned they might have to divert clinicians, so clinical capacity, away from providing face-to-face consultations to work on triaging this sort of potential avalanche of online requests. And we reported in the past week that some practices have had to do exactly that. Others are taking on extra staff to try to cope with the extra workload. So there's a direct financial impact on practices from this change. And existing staff are also having to work late, and some practices have begun to operate things like waiting lists, which, again, was something that GPs warned about over the past few months as a likely consequence of the changes to online consultation systems. We're now seeing the real world impact of these changes, and for all the government's efforts to dismiss GPs' concerns as scaremongering or label them as laziness or whatever, the fact is that many of the problems GPs predicted are now very much in evidence.
You kind of touched on it there. We also had the results from our own poll on this that showed these concerns. Over half of GP partners and practice managers that responded to our poll said that the change would lead to a cut in face-to-face appointments in their practice because of what you were talking about, them having to divert people away to dealing with these triage problems. 70% of GPs and practice managers feared the change to online access would have a negative impact on patient safety, and 85% said the changes would increase workload in their practices. I think one of the real concerns that came through from the responses to the poll was this requirement for practices to keep the systems on until 6:30 p.m. They have to be open between core hours. It's 8:30 a.m. to 6:30 p.m. One GP who responded to the poll said that they were managing online access really well before this change came into effect, but they turned it off before 6:30. But they had it open earlier in the morning so that patients could kind of submit requests before they headed off to work. And the changes have basically resulted in them, really considering just opening it within core hours and offering a service that is basically not as good or not really what their patients wanted. And that GP was arguing, what's the point of having it open between 3:30 p.m. and 6:30 p.m. if it's only supposed to be for non-urgent queries? Why do you need to have it open for those last couple of hours of the day? And obviously that 6:30 cut-off means that some people are going to have to stay late to process those queries in case anything urgent's come through. Yeah, I think that is a real issue. And I think the waiting times are also going to be an issue. Like people I've been speaking to have said that this kind of growth in workload that's coming through online systems means that what would have been maybe a 2-day wait for an appointment is now going to be a 5-day wait for an appointment. And as we head into winter, that become even longer potentially, 7-8 days wait for an appointment. Part of the issue is the way it's been communicated to the public. There's been a lot of comms going around on social media in particular that this is a chance for people to be able to book appointments online with their practice. And we've even heard where streetings say it should be as easy to book an appointment for the GP practice as it is with a hairdresser. But this isn't about booking appointments online, is it? It's about being able to submit non-urgent requests through an online consultation system online, and then someone will tell you how your query is going to be dealt with. So I think all of that communication is also adding to problems that practices are experiencing as well.
Talked about before that the government doesn't really seem to be listening to the concerns that GPs are raising about this.
No, absolutely not. If anything, they seem to have really doubled down on this, haven't they? And decided that this is the fight they want to have with the BMA GP committee. And it does feel like a bit of a fight, to be honest with you. If people haven't listened to our episode earlier this month from the RCGP annual conference, I would urge them to have a listen. There's some audio in there from what Health Minister Stephen Kinnock said at the conference. And it was really combative language he was using, accusing the BMA of whipping up the issue, describing it as a phony war. He basically said that none of the BMA's so-called doomsday scenarios, increased workload, urgent cases coming through online, he said that none of those had come to pass. But actually, that morning was the morning we ran that story of Kimberley's. 10 days afterwards, this is what practices are telling us is going on. And those things obviously had come to pass. Stephen Kinnock's view, and I think the view of the Department of Health as a whole, is we negotiated this with the BMA, they knew it was coming. Why are they raising all these issues now? That seems to be the standard line coming out of the Department of Health when we've queried them about this. And Wes Streeting has said exactly the same thing. But as you say, we know for a fact that the BMA has been trying to talk to the government about these concerns ever since the contract was agreed back in February. And I've been speaking to quite a few GPs and practice managers in recent weeks about this. And I've spoken to a couple of people who've been doing online total triage for a while, well before this contract requirement was ever mentioned. And they've told me that it takes quite a long time to change your system to introduce this. Some of them were saying they've spent 6 months before they even launched it, working it all up. And the government's argument would be, well, we've given practices 6 months to do that. We've given them the time to introduce it. But I think lots of practices were expecting more guidance. They were expecting more tools to be put in place by the system suppliers. That's what the contract agreement was based on. And so many practices will have been waiting for those things to happen before they made their changes. And now they feel they've been left a bit high and dry and scrabbling around to introduce it at the last minute. The BMA, as we've said repeatedly, did agree this on the proviso that those safety measures would be introduced. But the BMA GP committee last week wrote to members and said that despite repeated efforts from their side, the government did not meet with them or with any of the system suppliers on online consultation platforms to discuss this. And the BMA is basically saying that's a broken promise from the government.
It's also worth mentioning that practices that have done this previously, before the contract change took effect, actually implemented this change in the context of quite a bit more freedom without the sort of very specific rules that the contract brought in about how it should be done. There's been quite a sort of heated exchange of letters between the government and the BMA about all of this, hasn't there?
It's safe to say relationships are very strained at the moment. The first letter exchange we've reported on came about because of a really very unfortunate incident in the northeast and North Cumbria. A message about online access was accidentally sent to some practices in that area from an LMC, basically suggesting that they may need to divert patients to A&E. And that was picked up in the Times, basically because the ICB in that area got very cross about it and said that this message was suggesting that GPs were saying that their patients should deliberately go to A&E to overwhelm AME and to make a point. Although, I think that is their interpretation of that communication and it could have been read in a different way. But as I say, it was never official LMC guidance. It was a mistake. It was sent out. It was an internal discussion email that accidentally got sent to a handful of practices. That issue's all calmed down now locally because everybody seems to be realising it was an error and they're all on the same page. But, the Health and Social Care Secretary, obviously Wes Streeting, decided to use this as another chance to have a real pop at the BMA GP committee. He wrote to the GP committee chair, Dr. Katie Bramwell, and accused the BMA of showing a complete disregard for patients, of fostering an environment that had led to LMCs making rash interventions over online access. And he accused the GP committee of dangerous extremism. Again, really combative language being used by the government in a very high emotive situation where, tempers are already a bit on edge and everybody's a bit stressed about it. So then Dr. Bramwell replied to that letter and she implored Wes Streeting to meet with her to discuss GP's concerns. She said her practice, which is one of those practices that has operated online total triage for a long time, so before this contract requirement, she said that her practice has seen a 25 to 30% increase in workload since the 1st of October. So that's the kind of magnitude we're looking at. She again used that term that the government had broken its promises on safety measures, and that, coupled with concerns about the 10-year plan and how the Carhill formula overhaul is going to work, meant that many GPs are really worried about the future, and as a result, Wes Streeting has basically lost the trust of the profession. Resident doctors have also announced a 5-day strike for next month, and while obviously that's got nothing to do with the GP dispute, I think there's no doubt that will be feeding into Streeting's view of the BMA. Obviously he's not happy about that resident doctors strike. And I don't know if people remember, but before Labour was elected, Wes Streeting did talk about being prepared to take on what he called vested interests at the BMA. And I wonder if he's starting to see this whole thing as a battle that the government has to win. Certainly, as we've talked about, the language is all very confrontational. And I don't doubt for a second that he thinks that expanding online access is in the best interests of patients, and that's what he's fighting for. But I think in the process of doing that, he's really missing out on hearing some valuable feedback from GPs working on the front line. And we also know the government didn't discuss the final version of the 10-year plan with the BMA at all. There are obviously huge implications for GP contracts within all of that. And I think that's what's most concerning about all of this, is that the government doesn't seem to be really listening to what GPs are saying. And, and that's not just what the BMA is saying, but also what frontline GPs are saying. Nick, the other thing is that there's been another letter, just as we were about to record this, basically, there's been another letter that Dr. Katie Bramwell sent to Wes Streeting, which kind of takes this on a bit further, hasn't there?
Yeah, the letter spells out a lot of the current concerns, but it also rattles through an absolute shopping list of previous sort of issues that simply haven't been addressed by this government and also previous governments, as well as some new ones, all of which just sort of deepens the sense that only 6 months on or so from what looked like quite a positive position when the profession had agreed a new contract with the government, the first time a contract had been agreed between the government and the profession for a number of years. There's now this sort of huge gulf between the two sides. We reported in the past few weeks about the government announcing a review of the Carhill formula. That's the formula that distributes core funding between GP practices. And the BMA has said for a long time, along with many other organisations, think tanks and so on, that Carhill is not fit for purpose, all sorts of reasons for that. The review is very much something GPs are behind. It's something that GPs want. But the BMA says in this letter that the review is now underway and GP leaders haven't been given any role in shaping that review, in leading the review. And it says that the BMA GP committee wanted to be involved because changes to the formula will likely be quite a big part of the talks on a major overhaul of the GP contract, which they're hoping to complete during this Parliament. And the letter warns that because GPs have been frozen out in that way, they're concerned and have no trust in the process. It also runs through concerns around the online consultation system changes and the safeguards the BMA wants. It highlights why this year's GP contract fell short of what general practice needed. There was this huge new funding that came, but it came alongside significant new costs, things like the employer national insurance contributions. It also came after years of long-term erosion of GP funding, and it comes as the population is growing and ageing, so demand is expanding. And it also repeats demands that we wrote about earlier this year. So the BMA wants the government to confirm the funding envelope for the 26-27 GP contract, so for next financial year. And it also wants confirmation of how much money is available to support this big overhaul of the contract within the current Parliament. It also has asked for things like the additional roles reimbursement scheme money to move into a practice-based scheme. Then it reiterates some other points made over the past few years, demands for improved funding for GP estates, for example. So it just shows that all of these things, the BMA GP committee feels like it's shouting about these things. It's been shouting about some of them for a very long time. The message just isn't getting through, or at least isn't being responded to in the way that it wants. There's a list as long as your arm of concerns that GPs need the government to address as a matter of urgency. And many of them, GPs just feel they're simply being ignored on.
These are things that we've been talking on the podcast over and over again over the last few years, aren't we? And Katie Bramwell made that point actually in that first letter I was talking about to Wes Streeting, that, it's really disappointing that he's lost the trust of the profession because everybody was so hopeful to begin with. And I think that's what's quite sad about the situation we're in at the minute, because people did feel that there were reasons to be positive. But on the basis of what's going on at the minute, it just feels like the government isn't listening to what GPs need. I guess we're at the point now where we need to think about what happens now. So we know the BMA is in dispute with the government, primarily over online consultations, but obviously all those things you talked about are also rumbling away in the background. So where does it go next? And we could get an indication of what happens next at the England LMCs conference, which takes place next Friday, couldn't we?
Yeah, just to explain a bit what this conference is, it's the annual meeting of the local medical committee leaders in England, where they debate motions that then shape BMA or BMA GP committee policy if they're passed. So it's a coming together of local leaders of general practice. They're partly voicing concerns about issues affecting the profession. They're also often trying to exert pressure on the national BMA GP committee leadership to push for action to address some of those concerns. And also, like I say, just to sort of voice those concerns and put pressure on the government as well to give the BMA leverage, a sort of sense that these are things that GPs say they want. So that's why we're trying to negotiate them with you. We've got the agenda this week for the LMCs conference, and the motions listed for debate give us a sense of the mood in the profession and what GP leaders could decide is the way forward, both around the immediate clash around online consultation systems and all that stuff, but also in terms of sort of broader plans around potential industrial action and so on. We've been talking about escalation of action potentially for quite some time. The motions also reflect some of the points spelled out in the GP committee letter that we talked about earlier to Wes Streeting. One of the standout motions that's up for debate at this year's conference proposes the collection of undated contract resignation letters from practices across the country, and that would be to be used as part of potential industrial or collective action. So if LMCs vote for this, it would amount ultimately to a threat of mass resignation from GP practice contracts. So it's very much a nuclear option. It would be a massive step up from the collective action that we saw from the end of last year, the sort of measures like implementing safe working limits and that kind of stuff. There's also a motion expressing major concern about the way online consultation systems changes have been pushed through. That debate could see GPs demanding the changes scrapped, but also potentially threatening non-compliance with some of the requirements around access. The conference could also shape pushback, potentially in the form of industrial action, against the 10-year health plan. which is obviously the centrepiece of the government's thinking about the way forward on the health service. Motion listed about the need for GPs to have a leading role in changes the government wants, particularly around the formation of neighbourhoods. And GPs will debate refusing to take part in neighbourhoods unless they're GP-led, as well as drawing up advice for practices on how to block neighbourhood changes that could threaten the current partnership model of general practice, for example. So these are all very much the sort of concerns that GPs have been raising with the government, but again, stuff that they just don't feel is being addressed or taken seriously or listened to. There's a real mood of rebellion brewing, and if these motions are passed, and that feels fairly likely in the current mood, I would say, the government, is going to be facing another wave of action from GPs that goes beyond the sort of action that we've seen previously.
It will be interesting to see whether, because some of those things that we're talking about, like refusing to comply with online access, the BMA GP committee has been very, very clear that practices have to do this. You just have to do it, even if you don't feel you can. You've got to try and do it, because basically if you don't, you will be putting yourself in breach of contract, and that could open the practices up to all sorts of potential legal consequences. With
like we've said, the collective action previously was all stuff that did not put practices in breach of their contract, very deliberately, within that boundary.
Once they have had this discussion next week, I guess they will have to put all this to the profession again, won't they, in a vote as to whether or not this is the way we're going forward. So it's not like they're going to vote on it next week and suddenly everybody's going to say, right, that's it, we're not doing online consultations now. There's a process the BMA will have to go through before we get to any point where GPs are actually taking action. As you touched on, it's not just online consultations that are an issue as well. I mean, basically underneath all of this really is funding is a real problem still for GP practices, and kind of the online consultation debate has kind of really diverted attention away from this fact that practices are still really struggling financially, aren't they?
Yeah, so we mentioned earlier in the context of the impact of changes to online consultation systems that some practices have had to take on extra staff to sort of cope with additional workload following that change. Like I say, they're having to do that often from a fairly shaky financial position. Even with the significant new funding announced for this year's GP contract, the BMA said that practice funding remains well below the level it was at a decade or so ago in real terms. It's come with all these additional costs from national insurance, a rise in the minimum wage. Those sorts of additional costs have eaten away at a lot of the benefit of the new money that's come into general practice. And also, some of the money is not going into core funding. Some of the uplift is part of a boost to the additional roles reimbursement scheme, which is basically PCN, primary care network level funding. Our survey showed that most GPs and practice managers say that extra contract funding this year hasn't ended their financial worries. Around 2 in 5 said the contract had had a negative impact on their practice finances, and nearly half said it had made no difference. That's basically most of them saying there's not much positive to shout about. The government says it's giving general practice the resources it needs. That's one of the lines that it repeats quite often, and it generally points to £1.1 billion. The headline sort of extra investment in the GP contract is a big part of that. But the poll just suggests that isn't the way GPs and practice managers on the front line have experienced this. We heard from practices that have had to cut partner drawings, reduce use of locums or other staff to try to manage their costs. So financial pressures in general practice are still, like you say, a really big problem. And that's another big part of the backdrop, the mood that we've just been talking about ahead of the LMCs conference.
There's also some other potential flashpoints that are brewing as well. Last Friday, the government and NHS England released what's called the medium-term planning framework for the NHS. So this basically sets out the priorities for the health service from April 2026 through to March 2029. So it's the next 3 years. I mean, this is quite a big change because normally these planning frameworks usually only cover a year at a time. And this time they've done it for 3 years, which NHS England, the government says, this is brilliant now. It's going to give people a lot more certainty about what they're doing. It will unleash local innovation. So they think it's a really big opportunity. But anyway, there's lots to focus on in there, some really very ambitious targets around waiting times. But there's 2 areas that might particularly be pretty contentious for general practice. So firstly, unsurprisingly, access is a major issue in there. The government is suggesting introducing a new target that would require 90% of clinically urgent patients to receive a same-day appointment. That isn't a definite target. It's something they've said they will consult the profession about, but I can see those being quite tense conversations given everything we've been talking about today. I also personally think it's kind of quite unworkable, because how do you define what's clinically urgent, and how do you work out what 100% of those people are, 90%? And that seems like a really difficult definition to come up with. The framework also very much focused on stamping out unwarranted variation. This is Wes Streeting's big thing about stamping out unwarranted variation, but they really want to stamp out unwarranted variation in GP access. The framework says that's going to be key to developing neighbourhood health. ICBs will be expected to identify practices that are really struggling with access and put in place measures to help them improve. And another thing that I think potentially will cause problems is plans to significantly ramp up the use of advice and guidance from next April. So the framework says GPs will need to prioritise its use, not really clear what that means yet. And ICBs have been asked to identify 10 specialties in their area where advice and guidance can be most effective, and then commission care to maximise its use. The document says this, and this is quite important, it will be a key priority to work out how greater access to specialist advice and guidance and direct access to diagnostics can help GPs manage more patients without the need for referral. So potentially, that's all well and good, could be good for patients, but will there be funding, to come with this work? It sounds like practices will be expected to take on more work, but how are they going to do that if they don't get additional resources? I'm not convinced that the £20 per request for advice and guidance they get under the current enhanced service, whether that will be enough to cover the level of work this framework sort of suggests could be coming practices' ways.
And the total funding for that is also capped, isn't it? At £80 million a year, I think it was.
Yeah, one other thing to note about this is that apparently there is a model neighbourhood framework, which I think is due to be published next month. And apparently that is going to set out in more detail how ICBs, trusts and general practice should work together in neighbourhoods to deliver a new approach to elective care, which again, suggests more work for general practice. And it's crucial, if that's the case, that the money and the resources from the elective care budget is shifted into general practice to help GPs deal with this work. So that model neighbourhood framework document is obviously going to be really crucial, and we might see a bit more detail about how those new contracts for neighbourhoods are shaping up in that document as well. So that's a really important thing to look out for in November. Nick, we're talking about GP contracts and funding, but there's actually some good news on GP contracts from Scotland this week, wasn't there?
Yeah, in the context of everything we've just been talking about, it seems almost unimaginable, doesn't it? But in Scotland, GPs were also in dispute with the government. That's been the case since, I think, June or July. But that's now come to an end with a really major deal on funding for general practice. The government in Scotland and the BMA have agreed a 3-year package of funding worth more than £500 million in uplift in total, and that's across 2026-27 to 2028-29. And it's billed as the largest investment in core GP services to date in Scotland, and I'll talk about it in a minute, but basically you can see why. It means that by 28-29, recurrent GP funding is going to rise by almost £250 million a year compared with the current level. So total funding now in Scotland is around £1.3 billion a year. So adding £250 million a year to that total by 3 years from now is a really substantial change. And the aim is for that money to drive growth in the GP workforce, to create GP jobs. The bulk of the money is aimed at driving GP recruitment into practices, but rather than being through a scheme where general practice claims back reimbursement from a pot, as with additional roles reimbursement scheme in England, this is going to be paid to practices largely as part of core funding, and practices will then be expected to provide returns demonstrating how they've used the money to boost their workforce capacity. So it feels like a sort of higher trust project than the kind of approach that we've seen in England. And ultimately, it's a huge deal for general practice in Scotland. The profession appeared to be edging towards industrial action. In fact, seemed to be sort of taking almost a harder line than we've seen from the BMA GP committee in England, I would say. But this package of new funding has ended the dispute with the government and provide some real optimism for the years to come.
Yeah, as you say, it does feel very much in contrast to the position down here in England, doesn't it?
Yeah, it really does. The letter from the England GP committee I mentioned just now points to the Scottish deal. It makes clear that the funding general practice needs is provided, as is the case here in this Scottish deal. Disputes can absolutely be averted. There's not a problem. The Scotland funding deal amounts to nearly £42 per patient in extra funding by 28-29. That is really substantial. It's very close to the kind of funding that the BMA has been seeking in England in some of the documents that it's put out over the past year or so.
So moving on, let's talk about GP premises. Nick, you've been looking at funding for GP premises upgrades and how that money is spent. What's the funding we're talking about here?
So in October 2024, as a budget statement, the Chancellor announced a £102 million fund to support GP premises improvement. Clearly, that's a drop in the ocean. GPs have described it in that way. Lord Darcy said last year that a fifth of the general practice estate predates the NHS. Recent BMA polling found that half of practices aren't fit for purpose, and many more than that aren't fit for future purposes. This money was initially meant to be spread across 200 practices, but the government announced earlier this year that it would actually be split across around 1,000. So more practices are benefiting, but obviously with a smaller share of the total funding available per practice.
So how has the money actually been spent? Do we know who's benefited from this?
Yeah, I started looking into this a bit because basically the government had started talking about this funding almost in the past tense. Like it had already been spent, it had delivered improvements to patients' experience of general practice. So I was just trying to work out, had it already been spent and what had it done? And the fund is officially called the Primary Care Utilisation and Modernisation Fund. I don't think anyone felt they could pick an acronym out of that. The government has published 2 bits of information about it, really. There's a list showing the share of the total 102 million pot that each ICB in England has received. And then there's also a list of approved schemes. So it's basically a list of names of GP practices. We don't know from that how much each practice that's benefiting from the scheme is actually receiving. But what we can see is how many practices in each ICB area are receiving something. And we know, like I said, the total amount that each ICB has to spend. So we can see the average spend per supported scheme in each ICB area and get a sense of whether ICBs are sort of spreading it out thinly across a large number or sort of concentrating the money on a smaller number of probably bigger projects. What we found is there's a really variable approach, massive variation in how ICBs are spending that money, which, to be clear, they have to spend within the current financial year, 2025-26. So in some areas, we found that 2 practices are sharing the whole lot. So 2 practices out of all the practices across an ICB. Again, we don't know whether in that area it's split evenly between 2 practices or whether one's getting almost all of it even and one's getting a tiny bit. But anyway, potentially there's large redevelopment going on at 1 or 2 sites there. Whereas in other areas, as many as half of practices across the whole ICB are listed as receiving something. And that obviously likely points to a substantial number of fairly small projects, minor improvements, alterations to premises, that kind of thing. But, something that's much less likely to be delivering a really big increase in capacity in terms of rooms or something like that. But again, what we know from speaking to LMCs is that in those areas where the money's been spread more thinly or across a larger number of sites, there's actually quite a lot of variation in how it's being used. So in some cases, it's not an equal share for all of the practices within the ICB. What we're seeing is that some could be, potentially in line for quite a big redevelopment. Others could be getting a new handrail or something more minor. It might not be a minor thing for the person who benefits from it, but at the end of the day, a smaller scale project in many cases. There's a bit more detail in a story that we published earlier this month. There's a table that shows how the spending varies across England and proportion of practices in each ICB patch that are receiving something, the kind of amount that they're likely to receive on average, that kind of thing. So, I'd encourage people to go and have a read of that if they're up for a bit more information.
Yeah, we know that GP premises are in a pretty poor state, don't we? And there's real fears that without adequate investment into the primary care estate, the government just simply won't be able to deliver on plans to shift more care out of hospital and also plans to train more GPs, all of those things it says it wants to do, all of those things that were basically a manifesto commitment. What does the BMA and the RCGP and what do GPs say need to happen?
In all these surveys that we've talked about recently, I mean, obviously we talked about things like premises with mould. In the past, we've written about ones with sticky tape covering gaps in their broken windows and that kind of stuff. So, I mean, that shows you some of the sort of state of premises and the age of them and all that kind of stuff. To put that £102 million premises fund into context, it was a 2023 RCGP manifesto. They published like a 7-point manifesto, things that they wanted to happen. It was sort of in the run-up to the general election, basically. That talked about the need for a £2 billion investment in GP premises. That's the kind of order of magnitude that's needed really to deliver a substantial overhaul of GP premises. And I mean, if you talk about the Darcy thing I mentioned earlier, fifth of practices predate the NHS. There's a load of really, really old buildings and a load of buildings that just haven't had the kind of investment you need to make them modern facilities for healthcare. The BMA, RCGP are talking about the need for investment on a just a completely different scale from what we're seeing at the moment.
There's no sign that that's going to be forthcoming in any way, really, is there? I think we talked about that on the last news podcast, didn't we, about the potential for public-private partnerships, but that's really only in the context of these new neighbourhood health centres. So, there's not really any sign that funding is coming down the line, really, which is obviously another thing to be concerned about. Before we go, we've just got time for our good news slot, which this week is about end-of-life care. GPs, practices and practice staff have been recognised for providing excellent end-of-life care in the annual RCGP Marie Curie Daffodil Standards Awards. The winners were announced by RCGP President Dr Richard Vaughtry at the college's annual conference earlier this month. They were all selected based on their implementation of the principles of the Daffodil Standards, which are a set of voluntary quality improvement standards developed by Marie Curie and the RCGP. You can find a full list of the winners of the awards on our website. We'll put a link to that in the notes for this episode. We'll also put a link to where you can find more information about the Daffodil Standards, which is a really fantastic initiative that supports practices to improve end-of-life care, as well as care for bereaved patients. Anyway, huge congratulations to all of those winners who are making a real difference to patients and their families through the work that they are doing. Well, that's it for this week. Thanks for listening and thanks to Nick. We'll be back next week, so please do join us then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.